Bismillahirrahmanirrahim. Good day, everyone. Today we'll be sharing with you the most important updates in ADPKD, focusing on advances in understanding, diagnosis, and management in line with the latest KDIGO Guidelines 2025. I'm Dr. Mahmoud Sheikh, nephrology consultant and World Kidney Academy educator. Let's dive in. Today I'm going to walk you through the full landscape of ADPKD from basics all the way to advanced management and emerging therapies. The goal is to give you a clear, structured, clinically relevant approach that you can actually use in clinical practice. We'll start with a quick introduction just to align on what ADPKD really is and why it matters. Then we will look at the global prevalence, how common is it across different populations. We will also touch on the clinical burden, meaning what this disease really does to patients over time. Finally, we will briefly review the typical disease course, how patients progress from early stages to advanced kidney disease. Then we will move into genetics, which is central to understanding the concept of autosomal dominant polycystic kidney disease. We will discuss the major and minor cystic genes, especially PKD1 and PKD2. And more importantly, we will connect genotype to phenotype, how genetic variation translates into disease severity and progression. After that, we will dive into pathobiology. We will review the key signaling pathways involved in cyst growth, and we will break down the mechanism of cytogenesis in simplified and clinically meaningful way. Next, we focus on diagnosis and risk stratification. We'll go over imaging criteria, when and how to use ultrasound, CT, or MRI. We will discuss the role of genetic testing and when it actually adds value. And importantly, we will cover prognostic tools like Mayo imaging classification, ProPKD score, and error risk models. Finally, we will move to management, which is where everything comes together. We will start with conservative measurements like blood pressure control, lifestyle, and supportive care. Then we will discuss disease-modifying therapies, especially 12-10, including indications and contraindications, and how to use adjusted dose. We'll also cover advanced options like dialysis and transplantation, and we'll briefly highlight novel and emerging therapies that may change the future of autosomal dominant polycystic kidney disease. By the end of this lecture, you should have a clear step-by-step framework to approach ADPKD from diagnosis all the way to long-term management. So let's start simple. What exactly is ADPKD? It stands for Autosomal Dominant Polycystic Kidney Disease, and it's one of the most common inherited kidney disorders we see in practice. At its core, ADPKD is a dominantly inherited condition, meaning a single mutated gene is enough to cause the disease. These genetic changes lead to the formation of kidney cysts, but it's not just a kidney disease, it's a systemic condition with extrarenal manifestations affecting organs like the liver and sometimes the vasculature. The typical phenotype is pretty characteristic. Patients develop multiple bilateral kidney cysts that gradually increase in size and number over time. This leads to progressive kidney enlargement often long before kidney function starts to decline. Clinically, hypertension is usually one of the earliest findings and may be started to be relevant in stage 3 CKD. Many patients will also develop liver cysts as a part of disease spectrum. This is chronic, lifelong condition and is truly multi-organ in its behavior. It evolves slowly, often over decades, which makes early recognition and monitoring really important. In terms of progression, about half of patients will reach kidney failure by the age of 60. But there is significant variability, and this is where genetics and risk stratifications come into play. The key takeaway from this slide is that ADPKD is not just about cysts. It requires long-term structured follow-up, and in most cases, care from nephrologist and MDT will be needed in time of diagnosis and management and follow-up. Now, before we go deeper, let's understand the scale of the problem. ADPKD is actually the most common monogenic cause of chronic kidney disease. If we look at the genetic data, the prevalence is about 1 in 1,000. This comes from sequencing studies focusing on PKD1 and PKD2 mutations. So genetically, the disease is more common than we used to think. But clinically, we diagnose only about 4 per 10,000 patients. These numbers come from large registry data in Europe and the United States. And the gap between genetic and clinical prevalence tells us one important thing: there is significant underdiagnosis. In terms of outcomes, around 50% of patients will reach stage 5 CKD, and this typically happens by the age of 60. So this is not a benign condition, it has a real impact on long-term kidney survival. Another key concept is disease progression over time. total kidney volume TKV increased by about 5% per year. And this growth is almost exponential during adult life. This is why early risk stratification is so important. So when you put this together, ADPKD is common, underdiagnosed, and progressive, and that's exactly why it deserves early recognition and structured follow-up. Now let's move to how ADPKD actually presents in real life. Because many patients are diagnosed before they even develop symptoms, the typical diagnosis is made during asymptomatic screening, usually in someone with positive family history. So often you are not diagnosing disease, you are identifying risk early. Alternatively, patients may come to attention during evaluation of symptoms, most commonly flank pain, hematuria, or kidney stones. Hematuria is common presentation often due to cyst rupture or bleeding. Flank pain is very typically related to cyst enlargement, hemorrhage, or infection. Kidney stones are more frequent in ADPKD compared with the general population, mostly of uric acid nature. Hypertension is one of the earliest and most consistent finding. Headache is important, especially because of the association with intracranial aneurysm. Liver cysts are most common extrarenal manifestations, and hernias can occur due to increased intra-abdominal pressure and connective tissue weakness. So for this slide, I want you to simplify everything into one key idea. APKD behaves differently depending on the gene involved. On the left, we have the major genes PKD1 and PKD2, which accounts for the vast majority of cases, roughly 58 to 95%. These patients show the classic or typical imaging pattern, bilateral enlarged kidney with numerous cysts, usually symmetrically distributed. Clinically, this group tends to have more aggressive phenotype, earlier onset of kidney failure, especially with PKD1 compared to PKD2. They also tend to have more liver cysts and a higher risk of intracranial aneurysm. On the right side, we have the minor genes, each contributing less than 5%, like ALG5, LG8, and GNAB, and the others. These patients usually present with atypical ADPKD, meaning fewer cysts, asymmetrical or lobulated distribution, and often normal or only mildly enlarged kidneys. The disease course here is milder, with slower progression and later onset of kidney failure. Liver cysts are less common, and the overall systemic burden is lower. So the key clinical message, major genes like PKD1, PKD2 think typical severe and faster progression. Minor genes think atypical milder and slower disease, and this distinction is very important in real practice because it affects prognosis, follow-up, intensity, and treatment decisions like when and how to use tolvaptan and which patients are chosen. Now, shifting away from the kidneys themselves, this slide highlights something very important, the systemic and functional burden of ADPKD. Starting with fatigue, which is extremely common, affecting around 50% of patients, what's important here is that fatigue is not fully explained by kidney function or anemia alone, significantly impact daily life, work, caregiving, social activities, and even exercise capacity. In fact, even relatively young patients around the age of 30 can have about 25% reduction in aerobic capacity. Body image issues affect about 30 to 40% of patients. This is mainly driven by progressive abdominal enlargement due to kidney and liver cysts. This can lead to embarrassment and low self-esteem. And importantly, it has downstream effects, including social withdrawal, sexual difficulties, and even depression. Psychological burden is also very significant. About 30% of patients screen positive for mood disorders, and up to 30 to 70% experience moderate to severe distress. This is more common in women and is those with positive family history. Patients frequently report anxiety, depression, and what we call genetic guilt. Interestingly, many patients even express that they wish they hadn't known their diagnosis. Now, let's move into the genetic architecture of ADPKD, because understanding the genetics is the key to understanding variability in this disease. Most patients show autosomal dominant inheritance, but in real life, the story is not always that straightforward. Around 15% of patients actually have negative family history, and this is usually due to de novo mutations. Another 10% have intermediate family history, so absence of family history doesn't exclude ADPKD. There is significant genetic diversity in this disease. More than 2,500 different mutations have been reported in PKD1 and PKD2. PKD1 accounts for the majority of cases, around 70 to 80%. PKD2 contributes about 15 to 20%. And then we have small percentage of minor genes. These include genes like GNAB, IFT140, and the others. Each one of these individually accounts for a very small fraction of cases. This genetic variability explains why patients present so differently from early aggressive disease to much milder phenotypes. When next generation sequencing, we can now screen both major genes comprehensively and increasingly identify atypical or rare genetic causes. Now let's simplify this complex table into the key clinical message you actually need in practice. The goal here is not memorization, but pattern recognition. First, divide ADPKD into two major categories: typical autosomal dominant, mainly PKD1 and PKD2, and atypical ADPKD, mostly driven by minor genes. PKD1 accounts for about 70 to 80% of cases. This is usually the more severe form. Patients develop larger kidneys, more cysts, and earlier progression to kidney failure. PKD2 accounts for around 15 to 20%. It's generally milder, slower progression, and patients reach kidney failure much later, sometimes decades later. In typical ADPKD, you see bilateral, symmetrical kidney enlargement with numerous cysts distributed diffusely. In contrast, minor gene disease often looks different. Kidney may be normal or only mildly enlarged. Cysts can be fewer, sometimes asymmetric or even focal, lobulated. Minor genes like GNAP, DNA, GB11, and IFT140 and ALG genes are very rare, but clinically important because they often present atypically. These patients may have milder kidney enlargement, fewer cysts, sometimes preserve kidney function into older age. Some patterns may even resemble a autosomal dominant tubulointerstitial disease rather than classic ADPKD. PKD1 earlier onset of incision disease, often in the 50s. PKD2 later onset, sometimes in the 60s or beyond. Minor genes very heterogeneous. Many patients maintain kidney function for a long time, and only a subset progresses to end-stage kidney disease. Liver cysts are common in PKD1 and PKD2, often appearing by age of 40. In minor genes, liver involvement is variable. Some genes like GNAP may still have significant liver cyst burden. So the key message here is the phenotype is classic. If it's classic, think PKD1 or PKD2. If the phenotype or presentation is atypical, mild, asymmetric, or discordant with family history, always think about minor genes. And this is where genetic testing becomes very valuable. Now let's connect genetics into clinical outcomes, which is really where things becomes clinically meaningful. This slide summarizes how different mutations translates into disease severity. The first one, PKD1 protein truncating mutations, are the most aggressive form. These patients tend to progress earlier. The mean age of end-stage disease is around 53 years. PKD1 in frame insertion or deletion are a bit milder. The average of kidney failure is around 59 years. PKD1 missense mutations are even less severe. Patients usually progress later. Mean end-stage kidney disease onset is around 71 years. PKD2 mutation represents the mildest end of the spectrum. These patients often maintain kidney function much longer. The average age of end-stage kidney disease is around 80 years. But here is the most important message. There is significant variability even within the same family. So two patients within the same mutation may have very different disease courses. This means that mutations type alone is not enough for precise individual prognosis. You always need to integrate other factors, including imaging, total kidney volume, and clinical progression. Now let's go one step deeper into genetic complexity. Because ADPKD is not always a single mutation disease, modifiers can significantly change the phenotype. Deleterious modifiers. In rare cases, patients carry two mutations, either two mutations in ABKD or PKD1, or one in PKD1 and one in PKD2. These are called diogenic mutations, and the key point, they usually lead to more severe disease. These patients can present very early, sometimes even at birth or during early childhood. So if you see an unusually aggressive phenotype, always think about this possibility. On the other hand, not all modifiers are harmful. Some patients actually have protective modifiers effects. In certain families with PKD1 truncating mutations, about 18% show a milder phenotype than expected. This suggests that other genetics or environmental factors are buffering disease severity. Another important group, up to 15% of patients have no detectable PKD1 or PKD2 mutations. These patients often show atypical imaging patterns. They may have preserved kidney function and overall a lower risk of progression into advanced kidney failure. So the key message in that ADPKD severity is not determined by one gene alone. Always think beyond the primary mutations, consider diogenic disease in severe early cases, and consider modifier or alternative genes in milder or atypical cases. This slide summarizes the central pathophysiology driving cyst formation in ADPKD. Everything here resolved around loss of BC1 and BC2 function. When BC1 and BC2 drop below critical threshold, intracellular calcium decreases. This triggers cascade, CMB increases, mTOR is activated, and AMPK is suppressed. And the net result is increased cell proliferation, fluid secretion into cysts, and inflammation. At the cellular level, this leads to abnormal epithelial proliferation. There is also increased chloride and fluid secretion into the cyst via CFTR. Metabolically, the cell shifts towards glycolysis and altered energy handling, and importantly, inflammation becomes a part of the disease progression. Now, based on this pathway, we have several therapeutic targets. First, V2 receptor antagonism, tolvaptan, which is reducing CMB and slow cyst growth. Second, somatostatin analogs, targeting CMB signaling and particularly useful for liver cysts. Third, AMPK activation using agents like metformin or SGLT2 inhibitors aiming at that metabolic reprogramming. Fourth, targeting the PAP-A IGF-1 axis currently under investigation in phase 1. Fifth, microRNA 17 inhibition, which may restore BC1 and BC2 translation again. And finally, PKD1 correctors, allele-specific therapies still in early developments. Now let's move to the practical part, how we actually diagnose ADPKD, and the key is to follow structured stepwise approach. Step 1, we always start with clinical assessment. This includes family history, symptoms, and initial imaging clues. A positive family history is very helpful, but remember, absence of family history doesn't exclude the disease. Step 2, the cornerstone of diagnosis is kidney imaging. Ultrasound is a preferred initial screening tool. It is simple, widely available, and cost-effective. We use age-specific cyst criteria to make the diagnosis. MRI also can be used. It's more sensitive, especially in younger patients or early disease. Genetic testing is not required for every patient. It's mainly reserved for specific situations, for example, atypical imaging patterns, or patients with no clear family history like adopted patients. It's also useful in selected cases for prognostic or family counseling purposes. So diagnosis is based on integration, clinical phenotype, and family history, imaging findings, and when needed, genetic testing. This slide shows simple practical approach to diagnosing ADPKD in a patient presents with kidney cysts. We begin with imaging, usually ultrasound, showing kidney with or without liver cyst. The first key question is, do we have a positive family history of autosomal dominant polycystic kidney disease? If family history is present, if yes, we move to ultrasound criteria and typical imaging patterns. If the criteria are met, diagnosis is straightforward, is ADPKD, most likely due to major gene. If imaging is not clearly typical, then the diagnosis becomes uncertain. If there is no family history clear, we rely heavily on imaging pattern. Typical imaging still supports ADPKD diagnosis, but if the pattern is intermediate or atypical, we cannot confirm diagnosis at this stage. When diagnosis is uncertain, this is where further evaluation becomes important. Genetic testing for major and minor genes can help clarify the diagnosis. Advanced imaging like MRI or contrast CT may be better define cyst distribution and pattern. After this step, we usually reach one of three conclusions: either a confirmed diagnosis of ADPKD or another form of cystic disease present, or sometimes no definite diagnosis yet requiring follow-up and even more studies. Now let's move through one of the most important practical tools, the ultrasound finding and the diagnostic criteria. These are age-dependent and mainly used in patients with suspected atypical ADPKD. The diagnosis based on the number of cysts and the patient's age. And importantly, this applies in the appropriate clinical context, especially with family history. From age 15 to 39 years in this group, the threshold is higher sensitivity. If you see 3 or more cysts in total in both kidneys, the diagnosis is confirmed. Age from 40 to 59 years, here the criteria becomes stricter. 2 or more cysts in each kidney are required to make the diagnosis. If age 60 and above, in older patients, cysts are more common even in the general population. So the threshold is higher. You need at least 4 cysts in each kidney to confirm ADPKD. And also we have the exclusion criteria. Ultrasound is also very useful to exclude disease. In younger patients between 15 and 29, absence of cysts makes ADPKD very unlikely. Between 30 and 39 years, again, no cyst essentially rules out the disease. Between 40 and 59 years, fewer than 1 cyst in each kidney can exclude ADPKD. These criteria assume a typical imaging pattern. meaning bilateral kidney involvement with relatively symmetrical cyst distribution. If the pattern is atypical, these criteria may not be applied. Now let's focus on when and why we use MRI in ADPKD, because MRI is not first line, but is extremely powerful when needed. The main advantage of MRI is sensitivity. It can detect a very small cyst as small as 2 to 3 millimeters, compared to the ultrasound, which usually detects cysts only when they are like 5 or 7 millimeters or larger. Because of this higher sensitivity, MRI allows earlier diagnosis, especially in younger patients between 16 or 40 years. This is very important in screening at-risk individuals. MRI also provides more precise criteria. If you see more than 10 cysts in both kidneys, this is sufficient to confirm diagnosis. On the other hand, if there are fewer than 5 cysts in both kidneys in patients older than 20, this strongly suggests exclusion of ADPKD. So when we do actually order MRI, when ultrasound is equivocal, in younger patients where ultrasound may miss early disease, or when you need more accurate assessment for prognosis or research, fMRI can be performed, for example, in claustrophobic patients or those with non-compatible metal implants. A non-contrast CT scan can be used as an alternative. So, ultrasound first, MRI for precision, CT only when MRI is not feasible. Now, let's focus on one of the most important tools we have in ADPKD, total kidney volume, or TKV. Because if there is one biomarker that really predicts where the disease is heading, this is it. TKV is actually an FDA qualified prognostic biomarker, and importantly, is a stronger predictor of future GFR decline than age or baseline kidney function alone. So this shifts our mindset from just looking at the function to looking at structure and trajectory. In practice, TKV is typically measured using CT or MRI. We used the ellipsoid formula pi over 6 multiplied by length and depth and width. And to improve accuracy across patients, we standardize it into height, what we call height adjusted TKV or HT-TKV. The message here is consistency, same modality, same method, and ideally serial measurement over time, because again, we are tracking progression, not just a single value. Now, in setting where MRI or CT is not available, ultrasound can still give us useful information. For example, a kidney length greater than 16.5 centimeters in patients between 15 and 46 years old with preserved renal function strongly suggests rapid progression. Now, the key practical question, when should we actually order genetic testing in ADPKD? Because it's not needed for every patient. First indication, no clear family history. If you suspect ADPKD but there is no identifiable inheritance pattern, genetic testing becomes very helpful to confirm the diagnosis. Second, when imaging doesn't fit the classic pattern, for example, symmetrical cysts, few cysts, or discordant findings. If there are cases, in these cases, genetic testing helps clarify whether this is ADPKD or another cystic disease. Third, in potential kidney donors, especially younger at-risk individuals where you need to confidently exclude disease before donation. Fourth, in the context of assisted reproduction, genetic testing allows selection of unaffected embryos, helping prevent transmission of the disease to the next generation. When you decide to test, use a targeted next generation sequencing panel. And remember, PKD1 testing is technically challenging because of multiple pseudogenes with very high sequence similarity, so accurate interpretation requires advanced bioinformatics. Now let's move to risk stratification, because not all ADPKD patients progress at the same way. Identifying high-risk patients early is critical for management decisions. First, the non-modifiable factors. Male sex is associated with more severe disease. Early onset hypertension is a strong predictor of faster progression. Gross hematuria before age of 35 is another warning sign. PKD1 protein truncating mutations are linked to more aggressive disease, and patients with kidney stones or significant proteinuria tends to have worse outcomes. Now, the good news, some factors are modifiable. High salt intake accelerates disease progression. Smoking is associated with worse outcomes and would be strongly discouraged. Poor blood pressure control is a major driver of progression. High protein intake may also contribute to faster decline, and higher BMI, especially above 25, is associated with faster total kidney volume growth. In this slide, we are focusing on a key clinical question: how do we identify rapid progressors in ADPKD? Overall concept, we have three main approaches: imaging-based, clinical genetic, scoring, and longitudinal function. Each one has its strength, and they complement each other. Mayo imaging classification was the first very important. This is TKV based and currently the preferred tool according to the KDIGO. It uses height adjusted total kidney volume and classifies patient from 1A to 1E. Classes 1C to 1E indicates rapid progression, so there is the most practical and widely used method, especially when imaging is typical. Also, we have pro-PKD score, second one, which combines clinical and genetic factors. It includes mutation type, sex, early hypertension, and urological events. Higher scores indicate higher risk of progression, but remember, this tool is recall-dependent and less useful in younger patients under 35. Third, the ERA estimated-GFR slope, which is based on longitudinal kidney function. It requires a decline in estimated-GFR of more than 3 ml per minute per year over at least 4 years. It's simple and objective, but needs time and consistent lab measurements. Now let's move to management, including diet, lifestyle, and blood pressure as a part of conservative therapy, and also the disease-modifying therapy, and also management of complication like intracranial aneurysm or hemorrhage or cyst infection or polycystic kidney disease. Before we talk about advanced therapies, it's important to remember that conservative management remains the foundation for every patient with ADPKD. These measures are not optional, they are disease-modifying when applied consistently. Let's start with diet. We encourage adequate hydration, typically at least 2 liters per day to help suppress vasopressin. Sodium intake should be restricted to less than 2 grams per day. Protein intake should be moderate, around 0.8 to 1 gram per kilogram per day. And overall, a balanced diet with adequate fiber and controlled caloric intake is very recommended. Exercise is strongly encouraged at least 150 minutes per week of moderate activity. We do advise avoiding contact sports due to the risk of cyst rupture. And maintaining healthy body weight with a BMI target around 25 is very important. Lifestyle habits also play a major role. Patients should stop smoking, limit alcohol intake, and avoid nephrotoxic medications, and of course avoid recreational drugs. Blood pressure control is a central pillar of this, and we'll give it a special slide. Because beyond cyst growth, hypertension is one of the key drivers of progression and cardiovascular risk is in these patients. In younger patients aged 18 to 49 with early CKD stages G1 to G2, we aim for intensive blood pressure control. The target here is 110/75 millimeters of mercury or lower, and importantly, this should be achieved using RAS blockade, either an ACE inhibitor or an ARBs. This is not just about numbers, it's about modifying disease trajectory early. Now, for patients aged 50 or older, or those with estimated-GFR below 60, the target becomes more conservative. Here we aim for systolic blood pressure at below 120 millimeters of mercury using standardized office measurements. So the approach is individualized based on age and kidney function. If additional control is needed, we move to second-line agents. That includes beta blockers, dihydrogenase calcium channel blockers, and diuretics. But RAS blockade remains the foundation. Now, this strategy is strongly supported by HALT PKD trial. An early PKD intensive blood pressure control resulted in a smaller increase in total kidney volume. We also saw reductions in urinary albumin and left ventricular mass index. So there are both renal and cardiovascular benefits. Also, patients in the intensive arm had more frequent lightheadedness. So again, it's about balancing benefit and tolerability of patients. One key point, dual RAS blockade should be avoided. There is no additional benefit compared to monotherapy, and it significantly increases the risk of adverse effects. Now let's translate the evidence into practice when we should actually start Rivapena according to KDIGO 2025. This slide summarizes the key criteria in a very structured, stepwise way. First, we are talking about adult patients, especially between 18 and 55 years of age, and this population where disease-modifying agents therapies has the highest expected benefit. Second, kidney function needs to be preserved to a certain extent with an estimated-GFR at least 25 millimeters per minute. Below this threshold, the benefit becomes less clear and the risk-benefit balance shifts. Third, the most clinical element here is identifying rapid disease progression. This is typically defined as estimated-GFR decline of 2 or 3 millimeters per minute per year, sustained over at least 3 or 5 years, the past one. So we are not reacting to a single drop. We are looking for consistent trajectory. Then we refine our selection using validated risk stratification tools. Mayo imaging classification, specifically classes 1C through 1E, identifies patients with a higher cyst burden and faster progression. Alternatively, ProPKD score greater than 6 also indicates high-risk disease. Now let's move from how to treat to how we actually start and titrate tolvaptan in real clinical practice. This is a stepwise protocol-driven approach, but always needs to be individualized based on tolerance. We start with initiation dose 45 milligrams in the morning and 15 in the evening or afternoon. The key here is to introduce the drug gradually while allowing the patient to adapt to the aquaretic effects. If the patient tolerates this well, we are up titrating after at least 1 week. The next step is 60 milligrams in the morning, 30 milligrams in the afternoon. Again, we reassess tolerance, hydration status, and side effects before moving forward. The goal is to reach target dose 90 in the morning and 30 milligrams in the afternoon. This is the dose associated with maximal suppression of vasopressin activity and optimal disease-modifying effects. Once the target dose is achieved, we continue therapy long-term, ideally until the patient approaches kidney replacement therapy. So this is a chronic sustained intervention, not a short-term treatment. Now, just as important as up titration is knowing when to step back. We should consider dose reduction or temporary interruptions in several situations. For example, if the patient is on CYP3A inhibitors, if they develop intolerance or significant side effects, or if liver enzymes begin to rise. In certain cases, we may need to down titrate to lower doses like 30 and 15 milligrams, or even 15 and 15, or even 15 once daily in some selected cases. This flexibility is essential to keep patients on therapy while minimizing harm. So let's walk through the key side effects of tolvaptan in structured and practical way. First, the most commonly we have the aquaretic effects. Polyuria is essentially universal. Patients can produce more than 5 to 7 liters of urine per day. As a result, nocturia and urinary frequency are very prominent, and they significantly affect the quality of life. Patients may also experience polydipsia, which is expected due to free water loss. So clinically, dehydration is a real concern, especially if fluid intake is not adequate. And importantly, if the patient doesn't match intake to weight losses, hypernatremia can develop. Now, moving to the most serious complication, which is hepatotoxicity, tolvaptan can cause idiosyncratic liver injury typically within the first 18 months of therapy. You may see elevation in LT and ST, sometimes accompanied by an increase in bilirubin. This occurs in up to about 5% of patients. In rare cases, it can progress to clinically significant drug-induced liver injury. That's why strict monitoring is essential, and drug should be stopped if there is significant rise in liver enzymes. From a metabolic standpoint, tolvaptan can also increase uric acid levels, which may precipitate gout in some patients. There is also often mild increase in serum creatinine early on, usually due to hemodynamic changes rather than through injury. Patients may report also dizziness or lightheadedness, commonly related to volume depletion. Fatigue is also frequently reported in clinical practice. Finally, the drug interaction are very important. Tolvaptan has strong interaction with CYP3A like fluconazole and erythromycin, which can significantly increase drug levels and toxic risk. So in these cases, dose adjustment or even avoidance may be necessary. This slide summarizes when we should not use tolvaptan or when we need to be very cautious. First, absolute contraindications, meaning tolvaptan should be avoided if the patient cannot sense or respond to thirst. The risk of severe dehydration and hypernatremia becomes very high. And hypovolemic hyponatremia giving tolvaptan can worsen volume depletion. Anuria is another key contraindication. There is no benefit and potential harm and toxicity. We should also avoid combining tolvaptan with strong CYP3A inhibitors like ketoconazole or clarithromycin, as this markedly increases drug levels. Significant liver disease or prior tolvaptan-induced liver injury is a major concern due to hepatotoxicity risk. And finally, pregnancy and breastfeeding, where safety data are limited and potential harm exists. And there are also relative contraindications. These require caution and individualized decision-making approach. In advanced kidney, especially ischemia far below 25, the benefit is limited, while risk is very increasing. Baseline hypernatremia can worsen further with treatment. Patients who cannot maintain adequate fluid intake, such as elderly or cognitive impaired, are high risk of dehydration. Moderate CYP3A inhibitors may still be used, but with dose adjustment and dose monitoring. History of gout to hyperuricemia is relevant, as tolvaptan can increase uric acid levels. Concurrent diuretics, especially thiazide or leave diuretics, increase risk of dehydration and electrolyte disturbance. And elevate liver enzymes at baseline requires careful monitoring rather than immediate exclusion in mild cases. Now let's walk through the very practical and clinically relevant algorithm how to approach suspected tolvaptan-induced liver injury. This is critical because while tolvaptan is effective, hepatotoxicity remains the main safety concern that requires structured monitoring and rapid decision-making. There are three main entry points into this algorithm. First, a clear biochemical signal, AST, LT, or bilirubin rising to 3 times the upper limits of normal. Second, a more subtle but important rise more than 2 times the upper limits, or even more than 2 times baseline, even if still below the upper limit. And third, the clinical scenario, patients presenting with symptoms suggestive of liver injury like fatigue, nausea, anorexia, right upper quadrant pain, or even jaundice and pruritus. Regardless of how this signal appears, the first step is simple and decisive: hold tolvaptan. At the same time, you begin evaluating for alternative causes, other drugs, infections, and underlying liver disease. Next step, repeat liver function tests within 48 to 72 hours. This short interval is very key. You are trying to determine trajectory and not just single value. If liver enzymes continue to rise and reach 3 times the upper limit or higher, then tolvaptan should be permanently discontinued unless you clearly identify another cause and the injury resolve. On the other hand, if values stabilize or improve, you can consider reinitiating tolvaptan, but with close and frequent monitoring. In parallel, especially in symptomatic patients, you should actively assess for other etiologies, includes medications, viral hepatitis, autoimmune disease, biliary pathology, and if needed, involve hepatology early for additional workup. Finally, let's talk about one of the most critical aspects of using tolvaptan, safely structured monitoring, because the success of therapy depends not just on starting the drug, but on how to closely follow our patients. Before initiating tolvaptan, we need a comprehensive baseline. This includes kidney function with eGFR, serum sodium, and uric acid. Liver function tests are essential given the risk of hepatotoxicity. We also classify disease severity using imaging classification. And just as important, we educate the patient about polyuria and the need for adequate fluid intake. During the first 18 months, the monitoring is most intensive. Liver function tests should be checked monthly. This is because idiosyncratic liver injury can occur, particularly early in treatment, although uncommon, it can occur in up to 5% of patients. After 18 months, monitoring can be spaced out. We typically move to quarterly follow-up. At this stage, we continue to monitor liver function, kidney function, serum sodium, and uric acid. On a yearly basis, we reassess disease trajectory. MRI is used to evaluate total kidney volume and update. Mayo classification. We also review overall treatment response and ongoing indications for therapy. We also have to deal with the major complication management like cyst infection, polycystic liver disease, and also intracranial aneurysm or hemorrhage. Cyst infection in ADPKD is primarily a clinical diagnosis supported by labs and imaging. Start with history, fever, flank pain, and inflammatory markers like CRP and white blood cells. Urine culture can be negative, so don't rely on it to exclude infection. Initial imaging is usually CT or MRI, but finding may be subtle. In difficult or unclear cases, FDG PET-CT is the most sensitive tool to localize the infected cyst. Antibiotic strategy core principles. The key concept here is penetration, not just the spectrum. You need lipid-soluble antibiotics that can actually enter the cyst. Fluoroquinolones are first line, especially ciprofloxacin and levofloxacin, due to excellent cyst penetration and gram-negative coverage. Trimethoprim sulfamethoxazole is another strong alternative with good penetration. Chloramphenicol has excellent penetration, but is rarely used because of toxicity. Antibiotics with poor penetration like beta-lactam, ceftriaxone, tazocin have limited cyst penetration. Aminoglycosides such as gentamicin should be avoided when possible due to poor penetration and nephrotoxicity. This can be used initially in sepsis, but should not be relied on for definitive therapy. Treatment should be prolonged, typically 4 to 6 weeks. Shorter courses are associated with relapse due to poor antibiotics diffusion into cyst. If fever persists beyond 48 to 72 hours, reassess aggressively. Repeat imaging to rule out obstruction or perinephric abscess. Large cyst greater than 5 centimeters or non-responding infectious requires drainage. This can be percutaneous or surgical depending on accessibility. In rare severe cases with recurrent uncontrolled infections, nephrectomy may be necessary. Don't treat empirically without evidence of infection. If patient has pain without fever or inflammatory markers, think cyst hemorrhage, not just an infection. Now let's move to an important extrarenal manifestation of ADPKD, intracranial aneurysm. This is clinically critical because although many are silent, rupture can be catastrophic. Patients with ADPKD have about 4-fold higher prevalence of intracranial aneurysm compared to general population, and the risk is increased even more in those with family history of aneurysm or subarachnoid hemorrhage. Most aneurysms in ADPKD are small, typically less than 5 millimeters. They are usually located in the anterior circulation, and importantly, the majority are asymptomatic and discovered incidentally. The key symptoms you must never miss is thunderclap headache, Sudden, severe maximal intensity headache may indicate dental bleeding before rupture. This is a medical emergency and requires immediate evaluation. From a prevention standpoint, controlling modifiable risk factor is very essential. Strict blood pressure control, smoking cessation are the most important interventions. Screening is not for everyone, it's targeted. We screen patients with a family history of aneurysm or subarachnoid hemorrhage. Also consider screening high-risk professions or before major surgery or transplantation. If initial screening is negative but the patient is high risk, rescreening every 5 to 10 years is reasonable. If the aneurysm is detected, management should involve MDT care. Options include observation, endovascular coiling, surgical clipping, flow diverters, depending on size and locations. Now let's move to another important extraordinary manifestation of DPKD, polycystic liver disease. This is very common but often misunderdiagnosed, especially in terms of symptoms and management. By the end of 40 up to 80% of patients with ADPKD will have liver cysts. However, only about 5 to 10% will actually develop symptomatic disease. And importantly, polycystic liver disease is more common and more severe in women, likely due to hormonal influences. What really drives symptoms is liver volume. Once the liver becomes significantly enlarged, patients develop mass effect, symptoms like abdominal distension, early satiety, and discomfort. This is not the key point, this is not liver failure disease. Liver function is usually preserved, even in very large livers. So the problem is based on pressure, not hepatocellular function. From a medical standpoint, the main option is somatostatin analogs. These can reduce liver volume modestly around 2 to 8% over 6 to 36 months. So they are useful in selected symptomatic patients, but expectations should be realistic. For patients with dominant cysts, we can consider targeted interventions. This includes cyst aspiration with sclerotherapy or cyst administrations. In selected cases, segmental hepatic resection may be appropriate. In severe cases with massive hepatomegaly complications like portal hypertension, malnutrition, or severe symptoms, liver transplantation becomes the definitive option. Now let's move to renal replacement therapy in ADPKD, and this is where management becomes truly life-defining for our patients. We essentially have three main options: hemodialysis, peritoneal dialysis, and kidney transplantation, each with its own consideration in the context of a larger cystic kidney. Starting with hemodialysis, survival in ADPKD patients is generally comparable to other causes of chronic kidney disease, and in some cases even slightly better, likely due to fewer comorbidities. However, vascular access can be particularly challenging because the massively enlarged kidneys may compress central veins, so early planning for AV fistula is absolutely critical. Management of blood pressure often improves after starting dialysis, mainly due to better volume control. From a mortality standpoint, there is no clear difference between hemodialysis and peritoneal dialysis based on current observational data. One practical point: we should be cautious with aggressive UF in these patients, especially when there is significant abdominal mass effect, to avoid hemodynamic instability. Moving to peritoneal dialysis, historically it was underused in ADPKD mainly due to concern about space and complications. But current evidence shows that this is actually safe and effective in carefully selected patients. There is slightly higher risk of mechanical complications such as hernias, dialysate leaks, which is expected given the increased intra-abdominal pressure. Importantly, infection rates are not significantly higher compared to non-ADPKD patients. When technique is optimized, adequacy can be an issue in patients with very large kidneys because the effective peritoneal cavity is reduced. So patient selection is key. Using lower fluid volumes can significantly improve tolerability. Finally, kidney transplantation remains the gold standard therapy in ADPKD. It's associated with superior survival and much better quality of life compared to any modality of dialysis. In fact, ADPKD patients often do very well post-transplant, sometimes even better than other end-stage kidney disease population. An interesting observation is that native kidneys may decrease in size after transplantation, likely due to suppression of cyst growth. Importantly, there is no recurrence of ADPKD in the transplanted kidney. Whenever possible, living donor transplantation should be strongly encouraged as consistently provides the best outcomes for these patients. Now let's shift to a very practical and sometimes controversial topic: nephrectomy and ADPKD. This slide summarizes the ERA genes and kidney working group consensus, and it really emphasizes individualized patient-central decision-making. In general, nephrectomy is preferably performed during or after transplantation rather than before. Whenever feasible, laparoscopic approaches are favored over open surgery due to lower morbidity And importantly, the decision between unilateral and bilateral nephrectomy should always be tailored to the patient's clinical situation. Assessment of indication should be not rely on a single factors. We should use validated symptom questionnaires, involve a MD team, and most importantly, engage in shared decision-making with the patient. Key indication for nephrectomy. When do we actually consider nephrectomy? The most common driver is lack of space for future kidney allograft. Other important indications include recurrent cyst hemorrhage or hematuria, typically more than twice per year. Intractable chronic pain, especially when confirmed to be kidney-related. Recurrent cyst infections will utilize again frequent episodes. Significant GI symptoms due to mass effect, which can be quantified using tools like PLDQ. Recurrent kidney stones, dyspnea from mass effect, and overall symptom burden. There are also red flag situations if that pushes us more strongly toward interventions. These include several mass effect symptoms, as we mentioned, recurrent infection, bleeding, complicated stones, and suspected renal cancer. And of course, when there is simply not enough space, as we mentioned, it's the first reason. Timing is critical and often debated. Pre-transplant nephrectomy is generally reserved for last option, especially before kidney failure. The decision depends on the specific indication and whether a living donor is available or not. Post-transplant nephrectomy is often preferred if symptoms persist after transplantation, and in many cases, transplantation can proceed first, followed by delayed nephrectomy if needed. Now let's shift gears and look at where the field is going beyond tolvaptan. What you are seeing here is the evolving clinical trials landscape in ADPKD, and honestly, it's one of the most exciting areas in nephrology right now. We are moving from a single drug era into multi-target precision-based strategy. Starting with phase 3, there are therapies that could realistically change practice in the near future. The STOP-PKD trial is evaluating dapagliflozin and SGLT2 inhibitor versus placebo, focusing on eGFR slope and total kidney volume over 36 months. This is particularly interesting because it builds on strong cardiorenal data we already have with SGLT2 inhibitors. Then we have ADPKD looking at metformin, extended release, targeting AMPK activation again with outcomes centered on eGFR decline and composite endpoints. And finally, HydroProtect is exploring a very practical question: can we combine hydrochlorothiazide with tolvaptan to reduce serum volume and while preserving kidney function? And also, we are moving to phase 2. This is where things become more mechanistically sophisticated. ABBV-CLS 628 is an anti-PAP-A monoclonal antibody, essentially targeting the IGF-1 signaling axis, with outcomes focused on eGFR slope and kidney volume. AGLOW is evaluating BX407, a BC1 corrector specifically for PKD1 variants, representing a move toward genotype-directed therapy. This is a big conceptual shift. We are not just treating the disease, we are targeting the underlying mutation. In phase 1, we are seeing truly novel approaches. Our GLS8429 is the microRNA 17 inhibitor given subcutaneously aiming to modulate gene expression at the post-transcriptional level. And BYC003 is an antisense oligonucleotide designed to activate PKD1 expression. These are early, but they represent a whole new class of genetics and RNA-based therapies. So if we step back, there are therapeutic landscapes clearly expanding. We are targeting metabolic reprogramming, IGF-1 signaling, restoring polycystic function, and even modulating microRNA pathways. This is no longer just about slowing cyst growth, it's about precision medicine in ADPKD. To wrap things up, let's bring everything together into practical, actionable takeaways for daily clinical practice. Start with making the right diagnosis, integrate family history, age-specific imaging criteria, and use genetic testing when clinically indicated. And don't try on a single element. Think of this as a composite diagnostic approach. Next, risk stratify is a key. Use Mayo imaging classification as your primary tool when available. You can complement that with pro-PKD score of eGFR slope. The goal is to identify patients with rapid progression disease early. Then modify when we move to intervention. Optimize lifestyle and ensure restricted blood pressure control using RAS inhibition. And importantly, consider tolvaptan in patients who are high risk for progression. Then monitoring is continuous. Screening for intracranial aneurysm in high-risk groups. Follow for polycystic liver disease and cyst-related complications. This is a longitudinal disease, so surveillance is essential. Anticipate, always think ahead, plan kidney replacement therapy early. Transplantation remains the preferred modality when feasible, and decision like native nephrectomy should always be individualized. Then partner with your patient. Shared decision making is critical. Engage MDT care and focus on patient prioritized outcomes. Future perspective looking ahead, the field is moving toward precision medicine, gene editing, allele-specific therapies, microRNA modulation, and metabolic targeting all are emerging. These approaches have the potential to shift ADPKD from disease-modifying to disease-arresting therapy. Thank you so much for watching. Hope I gave you the concept and in a clear message. Hope to see you on the next lectures, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.